as promised to several of you, just a few quick examples of pathologies you've seen. Quickly tee up your axial T2 and your axial C plus T1, which can be found at the end. Far right, hit the number 2 to get them 2 up. Pull up a T2, anyone will do. Blow them up to the same size, and you will see a lentiform low signal area in the left globe. Enhancement on the MR. This is a 1-year-old. We said that most retinoblastoma occurs before age 5. Now, if you saw something like this in a 50-year-old, you'd think melanoma. As we mentioned, unilateral, 75%, bilateral, 25%. Our other case was bilateral, so we have to be highly concerned about a germline type of familial retinoblastoma. And tri- and quadrilateral retinoblastoma is 10 to 15% of all familial cases. This one's unilateral, doesn't involve the optic nerve, doesn't go back into the lamina cribosa, and doesn't involve the brain. So this is one that is lower staged, unilateral, probably non-germline type. Let's move on. Left orbit inflammation is the history. The patient is a female. She's 8. Admittedly, there's some patient motion. It's an 8-year-old. I apologize for that. Performed on a 3T scanner. But there are enough non-motion affected images to make anatomic observations. And while you're doing that, I might point out a few myself. There's preseptal swelling. See if we can find the septum. Might be a little tough with all this swelling. This might be the medial septum right here. But there's clearly involvement behind the septum. The entire globe, the choroid, the sclera, perhaps even the retinal layer, although they're difficult to discriminate without unilateral orbital coil imaging, but at least the sclera and the choroid are diffusely thickened on the left and slightly thickened on the right. My first thought would be orbital pseudotumor. Orbital pseudotumor can do pretty much whatever it wants. There are varieties of it, as we said, anterior, posterior, myocytic, lacrimal, and so on. But the patient has no pain. The patient is virtually asymptomatic, other than things look swollen, things are a little bit erythematous, there's no pain, the patient is not sick. You might say, well, okay, how about lymphoma? But lymphoma is bulky. It's a mass. It diffusion restricts. Yes, lymphoma can be infiltrative elsewhere in the body, but still, even elsewhere in the body, it tends to be bulky. But that would have to be in your differential, although the process is bilateral. So you have to think about something that could be bilateral. Another tip-off, potentially, to the diagnosis of this difficult case is the left lacrimal gland is swollen relative to the right. And it enhances with inflammation around it. Now, the remainder of the case is inconsistent with the number 1 malignancy of the lacrimal gland, adenocystic carcinoma. It doesn't have an infiltrative growth pattern through the right spaces, like the inferior orbital foramen, or into the pterygopalatine fossa, or the pterygopalatine space, or through the foramen rotundum, or Vidian canal to go posterior. It does none of those things. The patient is 8. 8-year-olds don't get adenocystic carcinoma. And the patient is virtually asymptomatic. So whenever I see a lesion that looks bad and the patient looks good, I think of sarcoidosis. When it's weird and I don't know what to say, I say, yes, dear. And I also say sarcoidosis. This is sarcoidosis. So it's a quick one. It's a diagnosis of exclusion. And you might have thought about endophthalmitis secondary to CMV or toxo, but the patient would have a greater degree of symptomatology, so the history just simply didn't fit. And those are causes of leukocoria. This patient did not have leukocoria, by the way, and has none of the signs of Coates disease, a lipoproteinaceous effusion, persistent hyaloid artery. None of those are present. So it's an inflammatory process. It's a benign one based on the history. That's how you come up with the diagnosis. Without history, you're really stuck. Loss of vision. Right eye. Now, in cases where we're assessing proptosis, I like to do things rather simply. Kind of one of the official ways to evaluate proptosis is to look at the zygomatic line and see how many millimeters the sclera sits behind the zygomatic line. And you can make that as a measurement. You're welcome to Google that and see what the ranges are. My preference is to simply look at how much of the globe sits in front of the interzygomatic line, and if it's 50% or greater, they usually have proptosis. But you're welcome to measure. On the far right is a higher resolution axial T2. There's a lower resolution one in the middle, smaller field of view, series 7. I would take you to image 8. I think that image immediately next to that is also informative. Image 8 from series 9. You might consider putting up the axial matching contrast-enhanced T1 MR, which is series 11. We'll leave the 2 sagittal contrast images for the end. I will give you the retention cyst or polyp of the sphenoid sinus. So another optic nerve intraconal problem. Same decision tree we have to make with our other optic nerve glioma, we must make again. Is this lesion coming from the optic nerve or the covering around it? And we must make this decision based on imaging, and these 3 images, axial T2, axial T1, and axial T1C plus tell the story, although in my opinion, the central one, the axial T1 non-contrast, and the T2 are most informative. What do they tell us? That we have a lesion that is very dark, which means it's desmoplastic, it's fibrotic, it's packed, it has very little cytoplasm, it's firm, it's hard, or it's calcified. Any or all of the above. Not a very good descriptive set of adjectives for optic nerve glioma. On the T1, the lesion looks like it surrounds a lower signal tubular structure, although that tubular structure is encroached upon. I'll make it a little lighter. And I would encourage you to make it a little bigger. I think the T1 contrast image is a little more amorphous in terms of its diagnostic acumen and capability, but there is enhancement in a more broad sort of perineural distribution. And I think now's the time for us to go to the sagittal T2. I'm going to brighten mine up and mag it up. I have both sagittal obliques up. So this case is like belly buttons, right? You either have an innie or you have an outie. So is it coming from the inside out or is it coming from the outside in? And I would suggest to you that it's coming from the outside in. Granted, it is difficult to see the optic nerve, but I do see it to here. And then it is buried in the center of this mass, but it doesn't look like it's expanding. It looks like it's being compressed. That's why it's so small and hard to see. And that takes me back to my T1. My optic nerve is kind of sitting in here, and the tissue is around it. Let's look at the T2. There's the optic nerve. So follow the optic nerve, and that would be the course of it. Most of the tissue that's abnormal is here and here, around it, and low. And how far back does it go? Let's return to the T1. It extends to the orbital apex, right back to the annulus of Zinn. So it's no wonder that this patient has loss of vision. Now, lesions like this that get back further into the third ventricle, which they can do, can cause hydrocephalus. So now you have optic atrophy on one side because you have choked the optic nerve, but you have papilledema on the other eye. That is called the Foster-Kennedy syndrome. The diagnosis you probably have now concluded is meningioma of the optic nerve. So it is not a second optic nerve glioma. It's important to make this diagnosis because if you biopsy a meningioma, you will make the patient blind. The treatment is radiation. This is a radiographic, not a histologic diagnosis. Let's flip over for a moment just for a brief discussion. Any optic neuropathy, any compromise of the optic nerve usually results in not just a visual field cut, but loss of color acuity. The patients may have other findings, including an afferent pupillary defect, which you learned about in medical school. The most common cause of optic neuropathy worldwide is glaucoma. Now, I'm not going to talk about this much, but the most common cause of optic neuropathy worldwide over the age of 50 is actually vascular disease and chronic hypertension. And this can be either arteritic or non-arteritic. I'm not going to speak about it today because it doesn't have an imaging correlate unless you're doing retinal angiography or retinal venography, so we'll stop right there. Let's move on to our next case. Remember, do not biopsy meningiomas based on their imaging characteristics. That's how the diagnosis should be made, and the treatment is non-invasive radiation. I actually did find the coronals useful. I am moving at a pretty fast pace. I found them a little bit less useful, but here is where I found it useful as I was previewing these while you were grabbing some food. The optic nerve is normal, not large. On the left, we see the subarachnoid space. And on the right, it's this tiny little dot that appears choked by a large, confluent, gray, desmoplastic, fibrotic signal mass on the right. So yes, it is useful in discriminating an outside-in effect versus an inside-out effect. Thank you for that. Those two slides that I showed at the end are not inconsequential, especially glaucoma. Overlooked glaucoma is a very common cause in younger individuals of optic atrophy. In fact, if I see it in a 35 or 40-year-old without an explanation, without MS, my first choice, I send them right to an ophthalmologist. You don't think about it because it's not a radiographic diagnosis. Normal ocular pressure is about 20 to 22, by the way. I think it's in millimeters. Okay, we have diplopia, double vision for 6 to 8 months. Patient is 50, I believe. Yep, 51. It is a woman. I'm sitting alone in my reading area, or maybe with some friends or visitors. I quickly toggle the sagittal and I go right off it because I know that it's an orbital history, and I will go to my orbital views. So here are my orbital views downstream. Now that doesn't mean I won't look back at the other views. I certainly will. But just to get a quick feel for the case, I'll go right to the area of interest. Now for those of you that are starting, registrars, younger radiologists, I would encourage you to stay away from the major pathology first. You'll get sucked into the pathology. You'll forget to look at the other abnormalities that are present on the scan that may be important. Yes, there is ethmoid sinus disease. I'll give you that. This time, the globes are fine. There's no retinoblastoma. I'm going to hit my 3-up button. I'm going to get a look at my optic nerves, which are very attractive, normal, symmetric. Let's draw a line between the anterior zygomas. I'd say there's greater than 50% of the globe in front of those zygomas, so there's proptosis. That's one way to do it. Or you could measure backwards in millimeters to the posterior sclera. That's a more complicated way to do it. Let's keep looking, shall we? And one of your colleagues commented on the value of the coronal, and it was valuable in that last case. It's particularly valuable when you're looking at muscles, the cone, the relationship of one optic nerve to the other, as your colleague pointed out. Nerves look fine. Muscles, not so much. They're a little bit large, aren't they? Now you might say, well, how large? Some of you that have not taken your medicine today, who are very OCD, might say, well, what's the measurement of the muscle? There is no measurement. It's called your experience. I think you'd all agree at least that this inferior rectus is a little too big. This lateral rectus is a little too big. I think you could postulate or posit that there's a little too much fat. But the fat isn't dirty, which it can be. So there's lipomatosis of the orbit. There are muscles that are enlarged. For Graves' disease, they're not all the typical muscles, which would be I'm slow, I am slow. And that would include the inferior and medial rectus, followed by the superior and lateral muscles. So that's a little mnemonic for you registrars. You're not slow, I'm slow. So not classic muscle distribution. Let's see if the muscle spindle ends are involved. No, they're nice and thin. They're nice and dark. They're nice and tapered. They are not involved. Let's get something with a little higher resolution. Contrast enhanced MR. Do we see some enhancing inflammatory pseudotumorous mass, a lymphomatous mass? No, we don't. But we do see delicate spindle ends of subtly enlarged muscles with hypertrophic fat and proptosis, which leads us to the correct diagnosis of thyroid ophthalmopathy. So now let's go back to the overall just straight brain. There's a polyp, there's some sinus disease. I think that's probably the guts of the case. Anybody have any other comments regarding findings? An aneurysm off of? Couldn't hear you. Let's see. On the sagittal or on the axial? Got it. Let's see if we can reconstruct it. I will tell you it wasn't commented on. Read by an excellent radiologist, by the way. Let's reconstruct it. I would say there's fusiform ectasia, but not an aneurysm. Would you all agree? Maybe that right there? Is that what's bothering you? So it wouldn't be off the tip, would it? I wonder if it's an atherosclerotic plaque with a flap, maybe with either an aneurysm or a pseudoaneurysm. I hadn't noticed it before, nor had my original colleague, and that's why we have 100 radiologists in the room reading these. Fantastic. I think you're right. I think it is abnormal. We'll go back and amend it. Beautiful. All right. Let's talk about thyroid ophthalmopathy. I don't think it's the tip, though. Do you agree with that? Okay. Yeah. I think it's this thing right here. Okay. Thyroid ophthalmopathy. I get free reads whenever I do these courses. It's fantastic. The reader, by the way, was a neurosurgeon for 25 years who then became a neuroradiologist. He usually accompanies me to this course. He's absolutely fabulous neuroimager named Malcolm Shupek. Although the last time he was here, he was a complete zombie. He couldn't get over the jet lag, which I have learned to overcome by starting to go on Melbourne time a few days before I leave the States. Thyroid ophthalmopathy. It can be categorized as mild, moderate, or severe clinically based on lid lag, retraction, proptosis for mild, moderate, soft tissue inflammation, intermittent myopathy. It usually stabilizes, and severe mass effect, and when there is mass effect, the sequela can be catastrophic. The patients can go blind. The treatment is usually medical, and the medical therapies are very successful. One of the more famous radiologists, chairman of the United States, suffered from this in the late stage or the severe stage of the disease and received oral medication, and he was better within 60 days, completely asymptomatic. I'm slow as the mnemonic for the distribution of thyroid disease: inferior, medial, superior, and then lateral, and then finally oblique at the very end. Symmetry in 70%. Dirty fat is common. Hypertrophic fat is common. They're usually middle-aged women. This is a middle-aged woman. It is the #1 cause of a unilateral, acute, or subacute onset proptosis in an adult, especially in a female. It accounts for 80% of bilateral proptosis and 15 to 30% of all unilateral exophthalmos. So if you've got a middle-aged female and you hear unilateral proptosis, you don't even have to look at the MRI. You just come out with, well, it's probably thyroid disease. There is an increased risk of myasthenia gravis, Addison's disease, and pernicious anemia in thyroid ophthalmopathy, and this triad is known as Schmidt's syndrome for your perusal and educational interest. The differential diagnosis includes pseudotumor, acromegaly, infection, metastases, and lymphoma. We said 2 metastases that, like the orbit, are neuroblastoma and breast carcinoma. They can produce enophthalmos or exophthalmos. Thyroid ophthalmopathy spares the spindle end of the muscle, unlike orbital pseudotumor. This is a male, 48. His eye popped out. He's now blind in the left eye. Now here's your trivia question of the day. Which dog, when it sneezes, has its eyes pop out? It's a Boston Terrier, but pug is number 3. Good guess. So I know many of you are not from Boston, but they're very common dogs in the United States. They're black and white, and when they sneeze, an eye pops out, and the vet can put it right back in. Just a little sidelight entertainment while you're looking. That is for real. I'm a dog lover. So in the left eye, there is globe contraction. There is slight enophthalmos. There are areas of septated fibrosis and blood. We would visually and clinically refer to this as phthisis bulbi. Let's continue on down to a coronal. In the middle, I have a T1 with contrast, and on the right, I have a T1 without contrast. And they have performed what I would consider a hated pair of sequences. I hate, I dislike, I detest when they perform the pre-contrast without fat suppression and the post-contrast with fat suppression. They should be identical. Pre, no fat, post, no fat, pre with fat suppression, post with fat suppression. But that has not hampered our ability to make the diagnosis in this case. Now, by history, allegedly there was a scleral buckle placed. I don't know how that relates to the phthisis bulbi. But I think I can convince you that there is proptosis and fatty hypertrophy, especially on the right. What about the extraocular muscles? They're big. They're all big. It would have been lovely if the medial and inferior rectus were bigger than the others, but they're not. There's a little bit of irregularity within the fat, not much. So not a lot of fibroinflammatory cicatrization present. Lacrimals look fine. It's a man, so that takes you a little bit away from Graves' disease or thyroid ophthalmopathy. There sure is a lot of proptosis, and there sure is a lot of fat. Now, what other conditions can enlarge the optic nerves? What other conditions can enlarge the muscles? Give me a few. Acromegaly, right? So your plain film findings for acromegaly, giant sinuses, big, thick calvarium. I don't think you could say absolutely not. I think the calvarium, diploic space, is a little thick. I think the sinuses are a little big. Let's take a look at the jaw. Not particularly prominent. Pituitary fossa. Unfortunately, most acromegalics have a microadenoma, so you wouldn't be able to see it at this resolution. Let's look at our coronal. Nothing. Nothing to suggest a pituitary microadenoma, but that has to be part of your search. What else is going to give you big muscles? The myocytic form of pseudotumor. That doesn't fit here for all the reasons we discussed previously. Exogenous steroids will produce muscular involvement and fatty hypertrophy. You want to know that. Or, does the patient have any other manifestations of Cushing's disease? You might want to know that. So all of those differential diagnostic considerations have to be winnowed out in this case. It's a patient with laboratory proven, diagnostically proven, and unfortunately lost his left eye from Graves' disease. Another example of Graves' disease. And you might be wondering, why does this globe look so funny? Why is it so irregular in the back, like it's stretched out? That's called a staphyloma. That is a compensatory abnormality that occurs in patients who are extremely nearsighted. It can also occur from secondary compression, like lipomatosis. It should be differentiated from a coloboma, which is an actual defect in the sclerouveal position, often near the optic nerve. So don't confuse coloboma with staphyloma, but that's a story for another day. Okay, let's do another one. Thyroid disease, secondary to Graves' ophthalmopathy. Nausea, malignant neoplasm of the head, face, neck. Please evaluate. In other words, rule out life itself. Since we know we're on globe, I will blow past my sagittal, although I would normally take a quick pass through it. And this is one for you to solve. So solve. While you're solving, I'm going to make sure there aren't any weird extraneous findings. And some of you may view this case as unfortunate in that there is been enucleation of the right globe, and there is susceptibility artifact with aspect ratio geometric distortion from surgical intervention, but that does not preclude evaluation of some critical findings. This case carries with it a high degree of difficulty. Now, when you're dealing with, we'll discuss this in the orthopedic course, when you're dealing with artifactual distortion, you want to stay away from gradient echo. You want to keep close to spin echo, and especially fast spin echo. You want to avoid manipulating your bandwidth. You want to keep the bandwidth pretty moderate. You want to keep the TE relatively moderate or slightly longer. You might want to stay with T1 imaging. You might want to stay with fast spin echo T2 imaging. And then there are some other techniques like Maverick and CMAC that we're going to discuss in the orthopedic section of the course that do apply to the head and neck. So the patient has a known malignant neoplasm, and there is a mass behind our area of artifact. It looks like it's passing along the distribution of the optic nerve, but as we follow it a little more inferiorly, we would posit that the inferior orbital fissure, which is located in this vicinity, is transgressed by this lesion. And then the lesion is going to come back, and it has several pathways of spread. It can go down. Usually when it goes down, it's going through the foramen ovale. To get from front to back, it may involve the pterygopalatine fissure, but it usually passes into the back to front foramen rotundum or the Vidian canal. So when you have this type of movement of a tumor that is ill-defined or irregular or kind of weaving its way around, and it's going from anterior to posterior, usually you're getting into the cavernous sinus, which we are, through the foramen rotundum. I'm going to show you through the foramen rotundum. We're going to show you some examples of high to low infiltration through the foramen ovale. So now I'm going to tell you that the patient's tumor came from the lacrimal gland. So all you registrars now know adenocystic carcinoma. Number one malignancy from the lacrimal gland, it's adenocystic carcinoma. And it's involving the skeletal lateral wall of the orbit. It involved the zygoma. It involves the adjacent soft tissues. And it involves the temporalis fossa. So it is a heavily infiltrative lesion. It's not just involving the intracranial space, it's involving the extracranial space and spaces in the face. This is adenocystic carcinoma, and it is typically a very serpiginous, growing, almost impossible to cure lesion. The take-home message here is anterior to posterior extension, getting to the slightly bulky, thickened cavernous sinus on the right through the foramen rotundum, and if you had a CT, you'd see Vidian canal. I would urge you to scroll to the far right while I take a more mundane route through the basic brain, making sure there aren't any basilar artery dissecting aneurysms. Hey, I'm a human being just like you. In my defense, I didn't read that case. However, offensively, I did review it prior to the course and did not see it. I apologize for some movement mismapping in this case. I am now on to the more orbit-centric images with a smaller field of view. And I have finally settled on the T2, the pre, and the post. So this is a T1 fat suppression contrast-enhanced image. The pre was performed without fat suppression, making it somewhat difficult to assess the amount of enhancement in this lesion. Although I must admit, it's not inordinate. It's intraconal, it's smooth, it's solitary. Let's now work our way over to a coronal, which I am hopeful we have. I believe we have one. Here it is. Oh, they stopped. Terrible. There's another coronal. There we go. It's a little highish in signal, right, on the T1 non-contrast? It's next to a muscle, but it's not arising from a muscle. It has a little bit of extraconal extension. The signal of it is predominantly high on T2. So it's not arising from the nerve. It's not arising from the globe. It's mostly intraconal. It's well marginated. It has fluid-like signal, but it is not simple fluid. It's not tubular, but that doesn't mean it's not vascular. Now, the most common intraconal mass in the setting of a younger individual with or without proptosis is a hemangioma, cavernous hemangioma. What is the other differential diagnostic consideration for cavernous hemangioma, which, by the way, respects the cone? The one that is less likely to respect the cone and dissect out of the cone, lymphangioma. Lymphangiomas are more likely to have higher signal on T1. Lymphangiomas are more likely to have fluid levels. Lymphangiomas are much more likely to bleed. According to the group at CHOP and others, lymphangiomas often have venous communication with the intracranial space, and some have actually characterized them as lymphovenous malformations. In fact, this is the more mainstream view of lesions like this. So your differential diagnosis should be between a cavernous hemangioma and a lymphangioma, but you probably ought to favor lymphangioma. Lymphangiomas also typically have an oval shape. This one has a rather weird shape. It looks like a saddle, an upside-down saddle on the far right image that I'm displaying. All right, so let's talk briefly about lymphangiomas. So these patients, unlike pseudotumors, have progressive, painless proptosis. They are hypoechoic, and ultrasound is a great way to make the diagnosis, especially in children. They have cystic spaces, and unlike hemangiomas, which may involute, lymphangiomas do not involute. They may alter in size with upper respiratory tract infections. So they can get a little bigger or a little smaller with a URI, which is kind of weird. That does not happen with hemangioma. They often present in the first decade. They're classified by size: simple capillary, cavernous channels or cystic channels, better classified sonographically. They're also classified by location: superficial lid or conjunctiva, deep or retrobulbar, combined superficial and deep, or complex involving the orbit and space. What do you do with a lymphangioma? You leave it alone unless it presents with an acute catastrophic hemorrhage that sacrifices or may sacrifice the optic nerve. Then it may have to be removed. Many lymphangiomas have varicoid or venous connections, thus the designation lymphovenous malformation of the orbit. It's a quick one, just a comparison. As many of you requested, want to see more than one example of each? Hint, hint, you've seen something like this before. While you're looking, I am going to scroll the whole case. There is some posterior ethmoid sinus disease. The orbital fat is normal or slightly increased. The orbital nerves look normal. Contrast was not given. I'm giving you a little more time because this is a finding case. Now, I showed you a meningioma earlier on. This is more of an example show and tell. I showed you a bulky parafalcine meningioma. I talked about its relationship to NF2, its abnormalities of chromosome 22, whether it's associated with NF2 or not. So we talked a little bit about the genetics. In children, meningiomas have a different connotation. You've got to search much harder for NF2. It's only 2% of childhood malignancies, of childhood neoplasms. The age on this patient is 32, so pretty young. We didn't get a chance to talk about mimics of meningioma and other histologies. So while I've been pontificating, I hope you have found the meningioma. It's not so easy. Anybody know what it is? Anybody see it? Compare the sphenoid on the right and the left. It's rather challenging. Look at the bulk on this side compared to the other side. You might say, well, why didn't they give contrast? They weren't suspecting the diagnosis. I think the standard T2 is really challenging. But that's real. It's not just on one slice. Look here, here. I'm going to blow it up a little more. Meningiomas are bland. They're fibrous. They're desmoplastic. They're solid. They contain very little fluid, very little cytoplasm. And this one is in very close proximity to the optic nerve and orbital apex. There's your optic nerve. Let's follow it back. Oh, it is getting encroached upon by this lesion right here. That's your optic nerve. So this is a tough one. Now, had you been given contrast, it would have been easier. But they weren't suspecting the diagnosis from the beginning. The history was blindness in one eye, and for whatever reason, they were considering MS. What are some other dural-based lesions that can simulate meningioma? Well, dural sarcomas can simulate atypical meningiomas. We talked about hemangiopericytoma, hemangioblastoma, but probably the big one is lymphoma, because lymphoma has a very similar signal intensity to meningioma, and certain dural-based metastases, the most notable being colon carcinoma, another one being prostate carcinoma. Granulomatous disease, not so much in my experience. Sarcoid and TB, not so much in my experience. Most meningiomas are typical. They can be broken down histologically into transitional fibroblastic and meningiothelial, and 8.3% of atypical meningiomas will be classified as a so-called grade 2 meningioma. We used to classify hemangiopericytomas as a grade 2 to 3 meningioma. That's now been removed from the meningioma designation, but there is a type called papillary meningioma, or grade 3, and many of these are aggressive, and there are anaplastic meningiomas, which are considered high-grade meningiomas. The World Health Organization has also subcategorized meningiomas as syncytial, in other words, dominated by meningeal cells, cap cells, fibroblastic, dominated by fibrous tissue, transitional, features of both, pseumomatous, that's the one where you see little flecks of calcification on CT, microcystic, also known as the humid meningioma, where there are small little secretory granules within, metaplastic meningioma, lipoblastic, yes, meningioma, may occasionally have fat, osteoblastic, the kind where you have very extensive reaction on CT of sclerosis in the surrounding bone, even chondroblastic varieties, myxoid varieties where you have a bright signal meningioma, 0.1% of all meningiomas, xanthomatous, and even melanotic. Okay, let's move on to another one. That's a subtle case of a sphenoid meningioma producing optic nerve choking, atrophy, and blindness, slowly progressive in the right eye. The history is articular cartilage disorder. See Dr. Lee protocol, which means Dr. Lee has a way he likes these done, and the customer is always right. So I do it the way Dr. Lee wants me to do it, as long as I can make the diagnosis. Dr. Lee is an excellent oral surgeon. With that in mind, let's look at how we make our clinicians look good. Let's talk about the TMJ. Clinically, these patients present with pain, clicking, sometimes locking, rarely trauma, but sometimes that trauma is something as innocuous as being hit in the chin with a soccer ball, so-called American soccer or European football. You might look for ipsilateral mandibular deviation, malocclusion, recent dentistry, recent orthodontia work. On imaging, you're going to look at the closed mouth view and the meniscal position, the open mouth view. I do not do cine movies anymore. I'm looking at the degree of capture. I'll explain. I'm going to look for closed lock, open lock, complete versus partial derangement. I'll look for meniscal tears, tears of the attachments in the bilaminar zone, masses, and the adjacent fossa in the infratemporal region. I'll look at the TMJ ligament, the parapharyngeal space, the condylar shape, and the articular eminence. I will also look at the degree of inflammation in the bilaminar zone. I'll show you where that is. The attachments themselves, whether they're stretched, not just torn. I'll look specifically at the lateral pterygoid, the IACs, the membranous labyrinth, the TMJ ligament, and I will often use the American Dental Association criteria for grading the severity of displacement. Okay. So here's my condyle. It's smooth and round. Here is my fossa. Like most joints, my joint will have cartilage. So here's my cartilage. Should be on the superficial edge. Sorry about that. I'll have some cartilage here. And then, unlike most other joints or some other joints, it'll be divided by a meniscus. And that meniscus has a biconcave appearance. So we'll make the meniscus kind of blue. It looks something like this. And I'm going to color it in just for effect. So the meniscus can tear right down the center, but rarely. Now, we have a capsule, which I'm not going to draw in because it's a little too difficult. But between that cartilage and the capsule, which is not drawn in, is a joint space. The joint space is divided up into an upper and a lower space. And that division is created by the meniscus and the ligaments and attachments of the meniscus. So let's make the posterior attachments brown. We've got one that goes down to the condyle. We have one that goes up to the squamotympanic fissure. Those attachments that anchor the ligament can stretch, they can break. They're more easily seen in the open mouth view. In the front, the meniscus is anchored by either a wispy set of ligaments or a dominant coalescent TMJ ligament. Now, the temporal bone continues on down as a bump called the articular eminence. So now let's look at the open mouth position. In the open mouth position, better make it a little thicker. In the open mouth position, I have my condylar fossa, my articular eminence, and now my condyle has translated and rotated forward. So there's both translation and rotation. How much rotation and translation? Variable. Can that condyle go in front of the articular eminence? It absolutely can, as long as there are no other morphologic abnormalities. So some patients have the ability to open their mouth very, very wide, especially politicians. But dentists know that they can get very large mouth opening in some patients and very minimal in others. And sometimes minimal mouth opening may be pathologic. So typically I see, if I make this a clock face, with this being 6 o'clock, I will typically see the condyle somewhere between 4 and 8 o'clock. And I consider that normal condylar excursion. Okay, now we have our meniscus. What's happening to our friend the meniscus? Our friend the meniscus that was initially at about 12 o'clock, so we'll make a little clock face right here. There's the center of our clock, and that would be 9 o'clock, that would be 3 o'clock, this would be 12 o'clock. Our meniscus, and by the way, this little center of the clock is right between the back and the front of the cortex. The top to bottom position of the clock really doesn't matter. But I have it usually equidistant. Whatever this distance is, that's how far down I drop my line. Do I make a line? Never. I eyeball it. But I want to see this structure line up with that or be a little behind it in the closed mouth view. That's normal. If it's about 8 degrees in front, that's still normal. Beyond 8 degrees, it's abnormal. That would be considered a closed mouth, mild subluxation. And you can grade the degree of displacement on the clock face. 8 to 20, 20 to 40, 40 to 60, 60 to 90. And those are the American Dental Association criteria, degrees of displacement, grades 0 through 4. And you can Google those at any time. You can get that off the internet. You don't need me for that, except just to tell you to get it off the internet. So now we're in the open mouth view. What happens? We've translated, we've glided, and our meniscus is now straddling the tip of the condyle. I prefer to see no less than 50% of this bow tie behind the 12 o'clock position of the condyle. So if it's 60%, that's okay. 50%, that's okay. Now what if the whole thing is behind there? That is not okay. And you'll see later on that when that happens, it usually stays there, and the patient's mouth is stuck in an open position. That's called an open lock. What happens if there's adhesions and this meniscus doesn't move at all when they open their mouth? It stays in front, something like this. Patient has opened their mouth, and now the condyle moves forward. And where's the meniscus? The meniscus is scrunched up over here like a little S. That would be absence of meniscal capture. Now, what happens if your meniscus was displaced? You open your mouth, and it doesn't capture. Complete internal derangement. What happens if your meniscus is in a normal or near normal position and you open your mouth and the meniscus does not capture? Partial internal derangement. What happens if the meniscus is displaced in the closed mouth position and the patient opens their mouth and the condyle doesn't move or moves a little? That's called a closed lock. What happens if the meniscus has busted, these ligaments have torn, they have rolled up in a ball? Let me make a new picture. Our meniscus, which we'll make aquamarine blue, is now back in here because the brown attachments, the upper attachment, and or the lower attachment, have busted. So everything is kind of circularized back here as a mass. The condyle is then progressively shoved forward. And now the patient is sitting there like this. They've got ipsilateral mandibular mouth opening or an open lock. And they can't move because there's too much pain. So we've got complete derangement, partial derangement, closed lock, open lock, American Dental Association criteria for displacement in the closed mouth view as a starter set for interpretation of the TMJ. You ready to get started? Not so much. All right, we'll keep going over it again and again and again. I've done many TMJs, and I have watched the evolution for the treatment of TMJ go all the way from the resection of a meniscus, which is catastrophic, to grafts of silicone and proplast, which work short-term but generate graft versus host reaction and eventually are catastrophically bad. I've seen some better procedures come along that include taking tensor fascia lata and other native material and placing it inside the joint as a gliding mechanism. Those are helpful, but they don't last very long. The best procedure that is now present, and for those of you that have daughters, for its young girls, women between the ages of 14 and 30 that get this syndrome. It's 20 or 50 to 1 women to men. The procedure that works is realtering the alignment of the mandible, which requires bilateral mandibular fracturing and osteotomy. Sounds awful, works great. Need an expert. The one thing I would encourage you to do is get a scout, because otherwise you'll be struggling to figure out which side you're on. You might take 45 minutes to read a TMJ, and then you get fired. Now, our technique is not a straight antero-posterior technique. It's not a straight orthogonal sagittal. It's an oblique sagittal that is perpendicular to the axis of the condyle. There's the condyle. Here's our axis. So we're starting out on the right side. Okay, this says closed. Problem number 1, closed. I want my condyle to be in the fossa. Is this condyle in the fossa? No, it's not. There is an abnormality of the modulation and conformity of the condyle with the fossa. Fossa is irregular, it's too shallow, the condyle is flat, it's got spurs, it doesn't fit, you have to acquit, the patient is stuck in a partially open position. How about the meniscus? Here's our meniscus right there. The back of the meniscus should sit 12 o'clock relative to the condyle or a little behind it. It does not. It's forward. It's almost 90 degrees forward, which would make this an American Dental Association criteria high grade, class 3 or 4. Where are the attachments? I don't see them yet. Okay, let's pick another sagittal. Left side. That should be better, right? Wrong. It's also closed mouth, but why isn't the condyle seated in the condylar fossa, where the bilaminar vascular zone is, where the attachments are? Because this condyle, too, is a little anteverted and flat on top. It doesn't fit. Because it's riding hard with friction against the articular eminence, the eminence is sclerotic. Where's our meniscus? Our meniscus is all the way out in West Australia in Perth. It should be over here, right? And where is its connection to the attachments or to the rest of the meniscus, which should look like a bow tie? There's no bow tie. There's half a bow tie. So we have a ruptured meniscus on the left. We have detachment from its attachments. and we have arthritis with an open position or an open lock position of the condyle. We're not done yet. Just because they're open doesn't mean they can't move. So maybe they can't close, but maybe they can still open so they can chew. Let's keep going, shall we? Chewing is good, although my recently deceased father said the most dangerous organ in the body is the tongue. Too much talking and too much eating will get you in more trouble than anything else you ever do. I think he was right. So the meniscus and its attachments will divide the joint into an upper compartment and a lower compartment. So when you're looking for fluid, you can see it up top, you can see it down low. We don't do arthrograms anymore. I haven't done one in 10 years, except in attorneys that I want to torture. So closed mouth view T2, no effusion on the right. Still a displaced meniscus, and look at the attachments. Squiggly, wiggly, not straight, not connected. These attachments are degenerated and torn on the good side, or the better side. Let's go to the opposite side. This time we have an upper compartment effusion on the T2, and we have a thickened attachment. It's still there. We have a condylar attachment. Let me blow it up. Condylar attachment, upper squamotympanic attachment, effusion. They're scarred to the back of the articular eminence, but they are not connected to the meniscus, which is down here as an S-shaped structure lying on its side. It looks like a little green worm. Let's keep going, shall we? We're still closed. It's a gradient echo. Actually, I take it back, it's a stir. It's a fat suppression sequence. I don't think it adds very much. It's on the right. Might do a little bit better job of showing an effusion. It doesn't. And while I'm scrolling through here, I am looking at the orbit, the sinuses, the membranous labyrinth, etc. Let's keep going, shall we? Stir on the other side. Reaffirms our effusion and maybe shows the anterior portion of the effusion a little better and some small fluid in the inferior compartment. So upper compartment fluid, lower compartment fluid. Here's our membranous labyrinth. We're still closed for God knows what reason. Let's go open. It's a T2 open on the right side, and the meniscus should straddle. So it should look something like this. Sorry. And in a healthy meniscus, young person, I like to see about 60% behind here. So some of you are saying to yourself, okay, well, what's this? That is all scar tissue. That is all thickening of attachment tissue. The meniscus is over here. Now the T1 should show that better. Let's see if we have a T1 open. We don't. But I will have many for you. On the worst side, where we had the effusion, with the mouth open, the meniscus stays anterior. Now let's answer another question. The patient has an open lock. Can they open their mouth further? So I suggest we go back to, let's 3 it up. So this is our left side open mouth. Let's go to our left side closed. Whoops. Wrong side. Correct side. So do they move? You control the horizontal, you control the vertical. Do you think this patient is able to open their mouth a little? Answer, yes. Condyle is over here at about 4 or 5 o'clock. Now the condyle is at about 6 or 7 o'clock. they do get some forced mouth opening. So they have an open lock, but they have restricted condylar translation. So how are we going to read this case? What's the conclusion going to look like? Let's go to the right side first. Actually, since we're on the left, let's do left. So left side. I'll say left side. Conclusion, left side, number 1. Arthrosis of the mandibular condyle with broad, flat erosions and reactive sclerosis of the articular eminence. American Dental Association criteria, class 4, subluxation with a partial open lock and associated effusion. Number next, mild condylar translation indicating mild ability to mouth open. Meniscus torn at the junction between the attachments and the meniscus itself. Associated arthropathic effusion, predominantly in the superior compartment. Right TMJ. Let's go to the right. Right TMJ, American Dental Association criteria, class 3 to 4 displacement, partial open lock, torn attachments, arthrosis predominantly on the condylar, but less so on the temporal side. And then let's decide how much translation we have. Let's go to the after. The open on the right. Are they able to open on the right? Yeah, they are. So open lock with modest condylar translation. So there is the ability of the patient to go from this position to this position. So it's not a closed lock. It's an open lock. So we'd have right TMJ, left TMJ, ADA criteria for each, displacement for each, translation for each. We describe these both as complete internal derangements. Why are they complete? Because they're displaced, the menisci, and they do not capture on either side. So bilateral, complete derangement. Probably starting with the hardest, most complex case. Okay, the history is a 17-year-old. They're all women. 17 years old. She's a girl. Jaw locking all the time. Pain when talking. She got hit in the jaw with a soccer ball prior to this occurring in 2006. So quite a while ago. So when she was 7 years old, she was struck by a soccer ball, and this has evolved since that time. A very common history. So I'm going to start on the left side. And I would suggest you follow along with me on the left side. I've put up the open mouth, T1, and the closed mouth, T2. Let's see what else we have. It's always nice to have the same sequence. So now I have the closed mouth, T1, and the open mouth, T1, side by side. I'm going to make them bigger. You can if you want. Now, it's not uncommon for me to start in the open mouth view because I see the posterior attachments nicely stretched out. The anatomy is often a little clearer. But in this case, I've got them up side by side. This time, the condyle is sitting in the condylar fossa. This time, there is not sclerosis of the articular eminence. And the meniscus should be right here. Should look like a bow tie. Maybe I drew it a little big. And the meniscus in the open mouth view should straddle, should be right here. And I think you would agree that is not the case. An amorphous structure, meniscal-like, is anterior, very far anterior, almost to Perth. And in the open mouth view, it exhibits no capture. So we already know we have a complete internal derangement with a high-grade subluxation of the meniscus on the left side. Let's put up the T2s. T2s are there really to show the attachments, the ligaments a little better. The squamous attachment or the upper attachment, intact. Lower attachment, harder to see, probably intact. There is a small effusion in the superior compartment. The meniscus is squiggled up in a ball in the open mouth view. The patient does translate to about the 4 o'clock position, so she's not locked, but she doesn't capture. So she's forcing her condyle forward. And it's basically cartilage on cartilage, bone on bone, eventually. In the closed mouth view, here's our meniscus. Posterior band, intermediate zone, anterior band. 3 zones. The posterior band is sitting at the 9 o'clock position. It's in Perth. It is a ADA class 4 subluxation on the right, without a perforation, with an effusion, with a complete internal derangement and some anterior translation. Let's go to the opposite side. Let's go to the right side. Hopefully that'll be a bit better. Let's put up the 2 T1s. That is not the right side. That should be the right side. It's not cross-referencing, huh? Pardon? Ah. There we go. Thank you. Okay. Doesn't look that much dissimilar from the other side, maybe with a few exceptions. These are both closed. Let's see if I can get an open one up. This is open on the right, closed in the middle. Very similar to the opposite side, with maybe one exception. Look at the top of the condyle is eroded. She's only 17 years old. This girl needs an operation before she is 24 and can't open her mouth or chew anymore. She needs that operation. Mandibular osteotomy realignment. She's a perfect candidate. And this will resolve. See if there's any more information that comes out of the T2. I doubt it. A little bit of an effusion. It's in the upper compartment as it usually is. This is clearly open mouth view, closed mouth view T2 on the right. And this is open mouth view T2 on the right. So on the right side, we've got another ADA class 4 subluxation, effusion, no capture, complete internal derangement. Let's do another one. Complete means displaced meniscus, open mouth view, no capture. But they don't necessarily lock. Some of them do, some of them don't. Locking means there's no translation. They're locked in a closed position. They can't open their mouth. And I'd say, well, why is that? Why can some do it and others not? Pain tolerance, but mostly adhesions. Adhesions are very painful. So the more adhesions they have, the less likely they are to be able to have reasonable excursion. Okay. This is a 37-year-old with buzzing in the left oral area. So what are the types of things that might cause buzzing? Pulsatile tinnitus, anomalous arteries, persistent corticobasilar anastomoses. You can actually even get it with otitis media, where the tympanic membrane is hypervascularized and the patient can actually feel the pulsation within the tympanic membrane. I know it because I have had it. Arteriovenous malformation, dehiscence of the jugular apex or bulb, or a high-riding jugular, an anomalous position of the carotid. Let's go to the contrast-enhanced MR. Glomus tumor would be one of the most important causes of pulsatile tinnitus that you wouldn't want to miss. Don't see evidence thereof. You could have one in the jugular foramen. You could have one in the tympanic canaliculus from Jacobson's nerve. You could have one arising from Arnold's nerve, a branch of the vagus nerve. We don't have any of those. But we do have a good view of our carotid arteries and our jugular bulbs. Now, if we have an anomalous carotid, these diagnoses are much easier to make on CT. The carotid will swing out laterally like this, especially on the coronal rotatory view of an MRA. See if we have an MRA. We don't. Got a very pretty view of the membranous labyrinth, which looks normal. Let's look at our coronal. Well, do we have that lateral swing of the carotid? The answer is no. It should swing about like this. It should come up and swing out laterally and then course over. Not doing that. So this is a pattern recognition abnormality. What about the jugular? It's a little higher on the left and the right. The flow is a little slower on the left and the right. So the answer is maybe. Not a very satisfactory answer. So what's a mother to do? Perhaps a CT. Let's see if we have one. Now this afternoon, it's going to be spine, blind case, spine, blind case. Back and forth, and we're going to go like mad. So be prepared. Don't eat too many carbs for lunch. Skip the lunch. No. They would hang me. So here are the carotid canals. It's not the most aesthetically pleasing CT I've ever seen. But I would say that's a very patulous and slightly high-riding jugular on the left, especially compared to the right, wouldn't you? And that really was the only finding that we could come up with in this individual. So it was a diagnosis of exclusion. The remainder of the middle ear was normal. There was no cholesteatoma. There was no glomus tumor. This is a patulous, slightly high-riding jugular bulb. Let's look at it axially. See, it goes up quite a bit of distance compared to the one on the other side, and there's even a suggestion of a little dehiscence of the vaginal or posterior process of the temporal bone. All right, let's do another one. That's a quick kind of show and tell. It's a complicated case. It's accompanied by a spectroscopy, which shows you the spectroscopy scale. You can see in parts per million what we alluded to earlier. Lower on the right, higher on the left. So 1.33 would be the region of the lactate lipid doublet. See, just to the left of that is NAA, which is a marker for neurons. So in the area that we have selected for pixel evaluation, this would be a single voxel map, spectroscopy map. The NAA is decreased. The NAA should always be taller than the choline peak. The choline peak is increased. Next to the choline peak is the reference creatine peak. Choline peak sits at about 3.2. And then downstream we have some other peaks that we talked about earlier. We spoke briefly about succinate, glycine, glutamate, glutamine, etc. And you can go back and look at your notes or go to MRI Online if you wish. All right, let's keep going. There are some other spectroscopy images that have been placed over various voxels. You can look at those at your leisure. You can grab your lunch and come back in. Now, why was the spectroscopy done? To see if any of these lesions had lipid, lactate doublets at 1.33. In other words, any of these lesions were malignant gliomas, specifically this one. The age of this patient is 9 years old. It is a male. Even though we're headed for lunch, I don't want to rush this case. There's so much to cover on our last day. So this is the lesion that was of concern. This is one of the lesions that had a voxel dropped on it, low NAA, elevated choline. Doesn't tell you much without one of the other metabolites rising like lactate or lipid, which it did not. Do patients with NF1 get gliomas? You bet they do. Do they get DNETs? You saw one yesterday. They do. But mostly they get fibroastrocytic dysplasia, which appears as focal abnormal signal intensity areas affectionately known as foci. And that is what you're seeing here. Extensive foci. Foci likes the globus pallidus more than the putamen. It likes the visual pathway a lot. It doesn't like the brainstem so much, but it does like the posterior fossa. So it's a little atypical that there's so much brainstem involvement, and this is a lesion of concern. It's inoperable, so what do we do with it? We follow it serially. You know, for perhaps there'll be a molecular treatment for this 10 years downwind, which, if it turns out to be a glioma at some point or degenerates into one, it'll be treatable. So that's really the only lesion to be followed. There are other foci lesions, astrocytic or astropillocytic dysplasia around the aqueduct of Sylvius. It's a little bit of putaminal involvement. And then we would go through our checklist for neurofibromatosis. Lambdoid sutural defects? No. Sphenoid wing defect? No. Optic nerves enlarged? Yes, on the left. Optic chiasm enlarged? Let's take a sagittal look at it. No. Brain tumor? Probably not, but one that needs to be followed. Superficial, soft tissue, neurofibromas? Don't see them. Perhaps incidental, perhaps not, because patients do get elastic deformation of connective tissue. That's why they get aortic aneurysms. So the presence of a cisterna magna pouch may not be an incidental finding. It may be related to NF1. That is a subject of debate. Let's go downstream a little further and see if there's anything else worth mentioning. I think not. Let's move on then to the next case. This is neurofibromatosis type 1. A few comments about it, especially for the registrars in the room. This is one of the genetic syndromes, NF1. Another one is NF2. Another one is familial schwannomatosis, found on the SMARCB1 gene. Then there's tuberous sclerosis, found on the TSC1 gene and the TSC2 gene. And there's von Hippel-Lindau. You've already seen Leigh-Fermani syndrome. Other genetic syndromes that result in brain masses and tumors include Gorlin, Turcott, Peutz-Jeghers, and Lermite-Duclos, all of which now have gene markers, gene maps that you can perform at any age. In NF1, the gene is chromosome 17q. It encodes for a specific protein, and it's a tumor suppressor protein like most of them. So lack of suppression is what usually results in these tumor syndromes. It's inherited as an autosomal dominant. It is spontaneous 50% of the time. So it shows up as a spontaneous mutation with no family history. They get cutaneous and plexiform neurofibromas, malignant as well as benign, peripheral nerve sheath tumors. By the way, peripheral schwannomas are much more common, and they get optic pathway pilocytic astrocytomas, or they can get astrodysplasia, which is more common. One of the most common findings in neurofibromatosis is what you see here. Foci, focal areas of signal intensity that are related to pilocytic astrodysplasia. These are not yet true neoplasms, and most of them do not become true neoplasms. I mentioned most of the bony skeletal brain abnormalities. I will mention the peripheral skeletal abnormalities in the MSK portion of the course. The foci lesions like the corpus striatum, the globus pallidus, the cerebellum, the optic pathway, which isn't included here, and also the thalmi. It's one of the causes of bilateral globus and bilateral thalamic hyperintensity, which is an important differential diagnosis. Vascular dysplasias occur in the body. The most threatening is aortic aneurysm. They can get secondary coarctation of the aorta, but in the brain, you can produce choking of both carotid arteries leading to moya with stenosis, and then secondary aneurysms and even pseudoaneurysms in patients with NF1. So they should have at some point an MRA. I think at this point, I'll stop and move on to the next case. If you're a registrar, you will be shown an NF1 on your exam, guaranteed. Deafness, surgery in a man, age 55. It is low field, but that's okay. Haven't shown you too many low field, mostly 3T and 1.5T. There's a lot going on here. He's 55 years old. He's deaf. He's had both 7th and 8th nerve complexes resected. And he's got nodules everywhere. And they're enhancing. So now your job is to figure out, diagnosis is already known, are these nodules in this NF2 patient meningeal, or are they cranial nerve related? Which means you've got to know where all the cranial nerves are. So it's an excellent exercise in anatomy. there's about a 50% chance your registrars will get shown in NF2. All right, so for instance, right there, we all know that the fifth nerves come out right there. Bilateral fifth nerve schwannomas. He's already had intracanalicular schwannomas that have been resected. It looks like he may have a schwannoma of the cochlea. Not uncommon, by the way. He's got schwannomas coming out of nerves 9, 10, and 11 on the left side, and smaller ones on the right side. These are left-sided schwannomas, not meningiomas, coming from 9, 10, and 11. And yes, they are all interconnected. So in the interest of time, let's just quickly talk about NF2. So we already spoke about the genetics of some of the major syndromes that produce brain masses and neoplasms. I've got them all listed for you here. NF1, NF2, familial schwannomatosis, TS, VHL, Gorlin, Leaf-Romani, Turcotte, Peutz-Jeghers, Lermite-Duclos. Unfortunately, NF2 is inherited also as an autosomal dominant. NF2, for your registrars, 2, chromosome 22. Meningiomas, chromosome 22. It's another tumor suppressor gene. It is much less common than NF1, which is the most common of all the fake homototic and all the brain tumor-producing heredofamilial syndromes, is NF1. That is a board question. The incidence of NF2 is probably about 10 times lower than NF1, somewhere in that vicinity. Patients get multiple intracranial schwannomas, meningiomas, and ependymomas, remembering the mnemonic miss me. All patients have a chromosome 22 Q12 deletion. The most common presentation is bilateral vestibular schwannomas. NF2 encodes for a protein called the Merlin protein, probably more than you want to know. And these patients do have a short lifespan. If you've got an NF2 patient, you have to go cranial nerve by cranial nerve, starting with the 12th. Did we look at the 12th? I'll bet we didn't. We're pretty rushed for time. Thank you. But right in the hypoglossal canal, there is a lesion. There's a 12th nerve schwannoma in this patient. There's another small one budding on the opposite side. Just an illustration of how you have to go through every cranial nerve from 12 all the way up to 3. There is a low incidence of schwannomas affecting the optic nerve. So if you're considering NF and you have optic nerve involvement, it's probably NF1. That is the one cranial nerve that favors NF1. I got this case bump in the middle of the night, emergency case from Children's Hospital of Puerto Rico. They said, girl came in the ER and she has a mass on her face. How long has she had it? I asked at 12 o'clock in the morning. They said, oh, it just came up. We just noticed it. Okay. Well, that should be something like a hemorrhage or a bleeding rhabdomyosarcoma or an aneurysm or a pseudoaneurysm or an infection or a cellulitis. The answer was none of the above, and the history was a fib. They were just scared. So one motion-affected image, not so pretty. Let's stay with a single image since it's time for lunch. And I prefer, I had it up there, this one, the first one. So here is the mass. It is pushing up on the inferior aspect of the orbit, but it is not arising from it. And we were able to make this diagnosis pretty quickly by following the mass. Let's follow it. Keep following it. It's now in Meckel's Cave, isn't it? Let's go forward from Meckel's Cave. What is that? That's the foramen ovale. Remember I said foramen ovale, up and down. foramen rotundum front to back. So this mass has come from Meckel's cave through the foramen ovale into the face. In a 5-year-old, without swelling, without edema, my diagnosis at 12 o'clock in the morning was, no, this didn't come up yesterday or today. This is a plexiform neural tumor arising from Meckel's cave, extending into the face. We actually have a picture of it. You could see it kind of sticking out of the patient's cheek, actually. Went inside the cheek and it's protruding inward. You're actually looking inside the child's mouth right here. And the image is reversed right to left. So this would be the left side. And here is the lesion kind of bulging out forward. You can see why the family was upset and alleged that this had just come up suddenly. They probably just noticed it. It's a plexiform neural tumor diagnosed by identifying the connection between the face, the foramen, ovale, and Meckel's cave. Let's take lunch.